practice right now, prime pediatric dentistry. And then on the lower right, this is when we practice, and we should be open in summer 2020. So that's my beautiful wife, Dr. Connor, April. This is a picture in the middle, Dr. Wilkes and I on graduation day. I think we just had a look for these couple of and then on the bottom is my fraternity brothers, Kappa chapter. I was class president here, so that was all the class presidents down there with our current, well, past president, Dr. Riley. And then up there on the top right, that's my pops. He's also a Meharry alumni. I think his classmates right here. That's 1979. So dentistry runs in our family. All right, so we're going to go ahead and get to it. We're going to talk about the Hall technique. So the Hall technique is a minimally invasive method for treating caries in a pediatric patient. Right now, like Dr. Wilkes said, parents are different nowadays. Parenting has changed from when we were kids or from when our parents were kids. You just can't talk to children a certain way or discipline them in a certain way. So a lot of parents don't want their children to have any adversity. They don't want them to cry. They don't want them to be upset. They don't want them to have any traumatic experience. So you're having to think outside of the box to get these kids in the chair and get it done. So, like I said, there's a growing trend of techniques and materials that are less invasive to the practice of pediatric dentistry. The general behavior management methods in pediatric dentistry, this is something that you'll see. Again, these parents, sometimes they're unreasonable. They know what kind of children they have. But, when they come to the office, oh, my child is dangerous. But they were just, had a temper tantrum requirement. So these are some of the behavior management techniques that we use. Sedation is one of them. Dr. Wilkes talked about that. General anesthesia, local anesthesia. As a pediatric dentist, I get asked about shots and needles. We call those the S words and N words in our office. And if I had a nickel for every time a child asked me, am I getting a shot? Am I getting a needle? I would be a billionaire. I get asked that every day. That's something that you have to be prepared for. And then, of course, we use something called the Kappa's word. We'll talk about that. So, conscious sedation. Conscious sedation can be used safely and effectively with patients who are unable to cooperate due to a lack of psychological or emotional maturity and or mental, physical, or medical disability. And the other thing that you consider when you're treatment planning these patients, you want to prevent a traumatic experience. Because when a patient, if you break their trust, or can hurt them, or you scare them, they're not going to come back. And if they have more cavities in their teeth or in their mouth that need to be fixed, you have a complication there. So that is something you have to consider with conscious sedation. General anesthesia is just what it is. It's a controlled state of unconsciousness accompanied by loss of protective reflexes, including the ability to maintain an airway independently, so they have a breathing tube down their airway to breathe for them. So it's serious. It's the same type of anesthesia that you'll get for getting a spleen taken out or getting a bone reset. So it's serious. And sometimes it's a hard sell to parents. Sometimes parents come in and they say, I don't want general anesthesia, and their kid has 16 cavities in their mouth. So you have to think outside of the box to still treat these parents, because some parents don't want to hear it. They will walk you out the room when you talk about general anesthesia. Lastly, again, this local anesthesia. You have to come with lots of tips, tricks, and distractions, but some procedures are just going to require an injection. There's no way around that. Of course, we all know what local anesthesia is, but it's the needle that is the pinnacle of behavior management in pediatric dentistry. Once you get past that, everything's smooth. But I'm shaking, my assistant's shaking, like, what this kid's going to do is a ticking time bomb. So sometimes if you can prevent the use of that, I'm all for that. Lastly is more non-pharmacologic behavior management tool, which is protective stabilization, which is the pathways board. I don't know if any of you guys have worked with that, but it is just what it looks like there. You're strapping the patient down the chair. I use those in residency. I personally just did not like that. It just didn't vibe with my practice of dentistry. And so I said that once I got out in the real world in private practice, that I was going to come up with a way to, we have to get to the point I have to strap your kid down, then we got to come up with another option. Because I wouldn't want to be strapped down, and so I just try to implement the goals of my practice. Okay, so just like Dr. Freddie said, we have some board trivia. I know who's preparing for boards? It's a real thing. Okay, great. So it's never too early to prepare. So we have some board trivia. I know Starbucks kept me alive during dental school, and I know that probably keeps you alive. So we have some Starbucks gift cards, so they'll kind of be scattered throughout the procedure. Our presentation. So this is Hall techniques, and so right now we're going to talk about kind of what the Hall technique is treating. And so it's known that cavities are a biofilm, and it's known that carious lesions develop when there's an imbalance of the film, which is ultimately going to lead to demineralization, and then you're going to have a hole in the tooth. And so as we know, you can drill and fill all day, but if you do not have a proper relationship with your patient in terms of dietary instructions, hygiene instructions, you can drill and fill all day, but it's not going to fix the process. So that's why you want to get ahead of it. We're going to kind of talk about that. So when you go to specialty training, or even when you get out of here, you do any kind of advanced training, the number one thing that your attendings are going to ask you is, show me the literature, show me the research, show me the journal articles. So we're going to kind of do a brief overview of some of the journal articles, because where I trained, you couldn't have a conversation with your attending if you didn't have a journal article to support what you're talking about, because otherwise it's your opinion and not fact. So when I'm talking to you all, we're going to have a proper conversation that's evidence-based. So like I said, Hall technique has been a game changer for pediatric dentistry. It's prevented me having to talk about the S word and the N word. It's a minimally invasive approach with a huge advantage in treating young apprehensive patients who may otherwise require surgical and sedation interventions of treatment. You also have to think about the evidence-based approach to it, because you just don't want to be doing things on patients that you do not have evidence that it's going to be successful. The worst thing as a dentist is when you have a patient coming back for something you already did, because that's wasting chair time, and then the patient's having to undergo another procedure that if you had properly planned for it in the beginning, you wouldn't be in that situation. So before I do something in anybody's mouth, I'm always looking at the evidence to see if it's supported by what I'm doing. So a little bit of background about the Hall technique. So it was invented by a general dentist, actually. It was not invented by a pediatric dentist who invented this procedure. And how they found out what was going on is that they did an audit of her. And so I don't know what you guys know about audit. An audit is when an insurance company comes in and figures out what you're doing, why you're doing it, and how you're doing it. And they're going to go through all your records, all of your x-rays, all of your treatment plans, and everything has to be right. And if it is not, you're going to be in trouble. So when you're getting your notes signed out, and they are, well, what's that? And what's the indication there? And what kind of, all that's important. And so what they found was that she was placing stainless steel crowns at an abnormally high rate. And she was also placing them in an unconventional way. And the unconventional way was no local anesthesia. And so back in 1997, before Hall technique was a thing, we were using conventional restorations to get things done. Stainless steel crowns, fillings, which all require local anesthesia, the S&N code. And then no tooth preparation. So the key factor for her clinical success was not necessarily her technique, but it was also the materials that she was using. So I know who's taking dental materials? Dental materials? Okay. And sometimes it's not the most interesting class, but you need to pay attention, because all of that stuff is going to be relevant when you get out of here. So the material that was kind of like her silver bullet was the glass ionomer. Glass ionomer cement has so many properties and so many advantages in the practice of pediatric dentistry. So this was kind of the thing that helped her have these successful restorations. So since 1997, there have been 4 randomized controlled trials published that demonstrate the efficacy of the Hall technique for caries management. So the first one here is sealing caries in primary molars, a randomized controlled trial, 5-year results. And so what that found is that Hall technique statistically, clinically, and significantly outperformed general dental practice standard restorations. And so the outcomes were comparable with standard restorations, and it strongly supported the Hall technique. So that's a game changer when you have journal articles that are supporting something that's kind of non-conventional. The next is caries management strategies for primary molars, 1-year randomized control trial results. And so the results here support the concept of caries control by managing activity of biofilm. They said that clinicians should consider Hall technique as treatment options with positive results. And so next you have the acceptability of 3 different caries treatment methods for primary molars with Lithuanian children. So that's a small country in Europe. And so dentists in this article reported that negative behavior with children with conventional restorations, meaning your composites, your crowns, the behavior was more negative compared to when they use the Hall crown. So that's more of a behavior management principle here. And then lastly, we have something that Dr. Wilkes talked about, which is the ART technique versus the Hall technique in primary molars. And what that found was that occlusal proximal, meaning that your class 2 lesions, restored with Hall technique showed better survival rates than the ones that were treated with the ART technique. So these are game changers. If you have people that are in the academic world that are supporting these techniques, that sometimes people are frowned upon that because they don't have the proper knowledge, they don't have proper experience, and so they can't recommend that. But these articles kind of started the advent of us using the Hall technique in the general practice of pediatric dentistry. So, just like Dr. Wilkes said, it's not going to work for everybody. So this is why you want to make sure that you know your contraindications and you know when it's going to be applicable to your patient, and you're going to have a proper result. So we'll go through the contraindications here. If you have any clinical symptoms of irreversible pulpitis or dental abscess, there's no clear band of dentin between the carious lesion and the pulp. If there's radiographic evidence of pulpal exposure or periverticular pathology, or if the tooth is unrestorable, these are not going to be candidates. You're going to have to do your traditional approaches. Lastly, children whose airway cannot be managed. So some of your special needs kids, like cerebral palsy, they can't maintain an airway, protect their airway. This is probably something that you don't want to use. So some benefits here. Patient-centered care. You can not only treat the cavities in the patient, but you're more able to treat the patient and what their needs are, what their behavior management needs are. All patients are different. All children are different. All tolerances are different. So this allows you to kind of read your patient, do a behavior assessment, and really treatment plan to that of your patient. It's quicker to complete. A Hall crown takes me about 2 minutes to complete, rather than a stainless steel crown that's taking about 10 minutes to complete. A Hall crown, we're in and out in about 2 minutes. Again, you have your proven efficacy by randomized controlled trials, and there's minimal intervention to the pulp. So anytime, especially with pediatric teeth or primary teeth, the pulps are very sensitive and they're very finicky. So if you can get around even negotiating or engaging the pulp, the more the better, because they will abscess on you quicker than an adult tooth, and they will cause more clinical symptoms in the primary pulp. So the Hall technique allows you to get away with that without having to engage or treat the pulp, which is a game changer. Again, this is important. Reduce anxiety, stress for the pediatric patient, parent, and me. So, you have to keep a cool face when you're working with these patients, but sometimes you don't know what's going to happen. You don't know if the kid's going to kick. You don't know if the kid's going to scream. You don't know if the kid's going to punch you. All this stuff happens in pediatric dentistry. So if we're able to employ a technique that kind of circumvents all that, that is going to be something that's going to make your practice more advantageous and more appealing to parents, because parents talk. I took my kid down the street, and the pediatric dentist told me I need to go to the hospital for 2 crowns. Or I came to Dr. Connor, and they did the crown in 2 minutes, the same crown. That's what helps build your practice. So these are things that are going to help you be more successful. Again, no need for local anesthesia or tooth perforation, no soft tissue damage. And the biggest thing in pediatric dentistry is numbing. So you kind of have to think back to the mind of a child. They've never been numb before. They don't understand that. So for 3 or 4 years, they're going with having feeling of their tongue, having a feeling of their cheek, having feeling of their lips. And all of a sudden, you just knock that out. And so a very common complication is that these kids will bite their lip, bite their tongue, bite their cheek, and have some very horrible presentations when they come back. So without us having to administer local anesthesia, that's a very, very big benefit. So this is a little case presentation. This is the lower left primary molar, so tooth number L. You see you have interproximal caries there. And so when you're talking to the parent, we give them informed consent, like Dr. Wolf was saying, and you give them options. You don't want to be the dentist that says you have to do this or you need to do this. I like to give patients options and the pros and cons of each, and let them arrive to their own decision, so that in the event that they pick something that has a higher rate of complication, you can document, hey, we had this conversation, we talked about the pros and cons and the possible complications of this procedure. So we gave her options. No treatment at all, that is an option. You can do monitoring of the patient. Silver diamond fluoride, which, like Dr. Wolf said, that the success rate on that tooth is not going to be very high because of the interproximal lesion there. Extraction of the tooth, A stainless steel crown. So the stainless steel crown, there are two options. You can do the traditional surgical preparation of the tooth, which includes local anesthesia. Sometimes it includes sedation. Sometimes it includes reduction of tooth structure. Or the Hall technique, which allows me to do none of that. So I can say, hey mom, we're able to get this tooth done, no local anesthesia, no sedation, no tooth preparation, and I can get your child done in 2 minutes. This mother chose the Hall technique. So we're just going to quickly go through the procedure here. If it's a Hall technique, it's truly, you're not using a handpiece and you're not using any local anesthesia. So in order to create that clearance interproximally, you're going to place orthodontic separators into the mesial and distal contacts to create space for the crown. So you can either use this with orthodontic pliers or you can use 2 pieces of floss. If the patient already has open contacts, even better, because I don't have to bring them back for a second appointment and get it done in one appointment. This is just a picture of those orthodontic separators we're talking about, and the bottom is where we use the floss to place the separators. Step 2 is you bring the patient back, allow the separators to sit for about 2 days to about a week. When you bring them back, like Dr. Wilkes said, sometimes they've had goldfish, they've had cheeseburgers, they've had french fries, and sometimes they don't brush their teeth before they come in. So you don't want that trapped inside their crown or getting pushed down subgingivally, which can cause more problems. So you want to do a nice quick cleaning with pumice and then rinse. That's a picture of that. And then the biggest thing here is protecting the patient's airway. So we use something called a throat screen. The worst thing in a pediatric office is a patient swallows a crown, or a patient swallows a tooth, and it happens. This actually happened at my hospital, and I had to send the patient down to the emergency room, had to get a chest x-ray. If that crown or that tooth is in the chest x-ray, you're in trouble. That's going to cause pneumonia, and it's going to be your fault. So if you're not able to protect the throat, then that's a contraindication to treatment. Another way you can secure the crown is putting a little piece of adhesive on your finger so that the stainless steel crown can attach to that, so you don't have issues with it just dropping somewhere that you don't want it to be. Next, you want to select the crown just as you do with a standard stainless steel crown preparation. You want to have a nice snap when it goes down. You don't want a passive fit with crowns. Stainless steel crowns require mechanical retention, so you want it to be a tight fit, and you also are relying on the adhesion from the cements as well. And so this is a picture here. You see the throat screen there on the right, and then you're doing your crown selection, putting the crown on. And then this is also a picture of that adhesive I was talking about. And again, when you're able to secure the crown, because like I said, you don't know what's going to happen. The kid is going to cry, kick, scream, yell, fight, curse. And if you're having to move your hands and the crown's going other places you don't want it to, this is a way to keep it on your finger and keep it secure. This is the important part of Hall technique. You want to fill the crown with glass ionomer or resin-modified glass ionomer cement. So this is going to bring us back to some more trivia. So this is a little bit of biochemistry, which everybody should be taking in. So fluoride inhibits the blank step of glycolysis and inhibits the rate limiting enzyme blank.
D. D.
No.
D.
Purple in the back.
It's going to be D.
Excellent. This guy here is the resin modified glass cement that you're doing with your crowns with. And then of course you're going to remove excess cement with fluoride with gauze, water spray, and phosphorus. It's also important that you want to remove all of the excess cement, because if you do not, you're going to leave excess cement underneath the soft tissue, which is going to cause an inflammation reaction. You're going to bring the patient back, you're going to say, hey, my child is complaining about this crown that you put in their mouth. You take an x-ray, you see this ledge of cement down there, which means that you're going to have to give the patient an injection, and you're going to have to scale to get that piece of cement off. So that's a very, very important part of this procedure here. Again, Dr. Wilkes talked about this. One of the benefits of primary teeth is that they self-occlude. So they self-occlude by intrusion. And so once you have the tooth finished, it's going to sit a little bit higher because you have not done any reduction on the tooth. So the crown's going to sit on top of where the tooth originally was. So it's going to sit a little higher. So what you'll see is that once the patient uses the tooth for about 1 to 2 weeks, it'll go right back into clearance and inclusion with the other teeth, and you're fine. So controversy. There remains some controversy regarding this technique in the U.S. And it often stems from a lack of awareness of the randomized controlled clinical trials for Hall crowns or the systematic reviews. And these reviews have demonstrated that complete caries removal is not necessarily required for caries management. So this is an article here, and I heard some professors like, what? Because that's an easy road to failure prep if you leave caries in the tooth. So a little quote from this article: the failure to follow new evidence is not limited to dentists who are out of touch, do not undertake continuing professional development, or have been practicing for many years. In some countries and schools, dentists are still taught to remove all infected caries tissue, and it is actually not possible to pass professional examinations without demonstrating this. And the reasons underlying this failure to translate evidence into clinical practice are many and complex. So like I said, for some people, they've been trained that if you leave cavities in the tooth, that is a failed restoration. And so what the Hall technique is telling you is that they are challenging the established way of restoring teeth. So that's something that some people can't get their mind across. In conclusion with the Hall technique, again, case selection is important. It's not going to work for everybody. The patient comes in, they're abscessed, they're having spontaneous pain, nocturnal pain, they're having issues eating, staying asleep. Hall crown's not going to work for them. You're going to have to do something with the cold. So if it's not for every patient, every tooth. However, it is an evidence-based procedure that is an extremely advantageous and attractive option for managing severe early childhood caries. This minimally invasive approach allows the provider to increase access to care and improve patient experience while reducing cost and risk. So this is a very important tool that you use in your arsenal so that you can kind of give patients more options and give them more ways to have a positive and rewarding experience while getting their teeth treated. So the next thing we're going to talk about is molar incisor hypomineralization. How many people have learned about that already? Okay. So this is something that you're going to see when you're in private practice, and when you see it, you're going to need to know what it is and how to treat it. Because I've seen some cases where they have gone to another dentist, it was not properly identified and treatment planned, and I see the patient on the other end of that. Now we're having to take the teeth out. Now we're having to do surgical procedures. But if the patient had been identified from an early standpoint, you wouldn't be in the situation. So the prevalence of MIH is 20 to 40%. It can affect one or all permanent first molars and or permanent incisors, or sometimes the primary and second molars. You're going to see demarcated enamel opacities with varying discolorations, such as whitish color, creamish color, yellowish color, or brownish color, bordered by sound enamel. This is another caveat with these patients. They are hypersensitive. They do not numb well. And so if you are just going in and treating them as a standard patient, thinking you can give them a block or give them infiltration to treat them, they're going to jump out of your chair. And then after that, you will not be able to treat them. So you need to be able to identify, hey, this patient has MIH. I need to come up with more options. Either they need to be sedated, or we need to do some education about what's going to happen to be prepared of managing the behavior. And again, these teeth are 10-fold higher risk of developing cavities. And in terms of what the cause is, it's really unknown. We're going to get to that in a second. So this was an article by the American Academy of Pediatric Dentistry. So they kind of created a guideline on how to treat these patients. You don't want to just sporadically or blindly manage these patients when they come in. Oh, you need a filling. You want to be able to say, hey, listen, this tooth is coming in, you have MIH. These are the things that we're going to do. So the first thing is risk identification. This is why the child needs to come in every 6 months to see us. And so when the tooth first comes in or partially erupted, I can see that it's got some compromise or complication. You're most likely going to have MIH. So now we can start talking about early diagnosis and remineralization and desensitization techniques. Number 4 is prevention of caries and post-eruption breakdown. So as a pediatric dentist, this is where I would like to stop MIH. I don't like having to get into the restoration and the management of these patients. We get to them in time, we can talk about sealants, we can talk about proper diet, we can talk about proper hygiene that will prevent these from turning into something that's going to be a problem for you. So a little bit of background. This is going to be kind of like our rubric for how we're going to move forward talking about MIH. So we're going to talk about the etiology, clinical challenges, prevention and home care, so topical fluorides, over-the-counter paste versus prescription paste versus varnish and STF. And then we're gonna talk about some more remineralization and desensitization techniques you can use for these patients. We're gonna talk about sealants and clinical management. And so this is kind of the surgical part of the management, which is where I don't like to be, but you have to be prepared in case you do that. And so some of the techniques, we learned about ART and SMART techniques, glass ionomer fillings, a Van and GIC technique, Hall technique, and the worst case scenarios, we're gonna have to do extraction and second mobile substitution. We also have some more clinical management, which are more aesthetic options, because again, you are gonna have the lesions developed on the permanent first molars, which you can't see, but you're also gonna have them develop on the anterior teeth, which you can see. So the child comes in with white spots, brown spots, yellow spots, the parents are gonna run away to address that and engage that lesion. So again, when you have a parent come in and you identify this, they're gonna say, oh my gosh, what is this? How did this happen? What did I do wrong? How can we fix this? And so this is also kind of like a spilt milk principle. Once it's there, it's done. It's calcified. They have gone through villagenisis. The tooth is formed. There's nothing you can do to fix it. So you just want to kind of give them some reasons. Sometimes some of the reasons will catch. Oh yeah, I had a rebirth, or they had some kind of medication they were on. So we'll kind of talk about that. So preterm birth or low birth weight is one of them. Environmental pollution, like fluorosis is one of them, is very sensitive to environmental challenges, and that's why the toxic effect manifests in the tooth defects. Lack of vitamin D, calcium, or phosphocalcic metabolic disorders will also contribute to MIH. And then childhood diseases such as mumps, rubella, bronchitis, asthma can also contribute to them because they're on some very powerful medications. When they are going through tooth formation, if you are interfering that formation process, then you're going to see it calcified on the teeth. Also, high fever is one of them. I've seen a lot of patients where we've kind of gone through this list of possible complications that have contributed to the patient's MIH, and the patients have said, yeah, they had a horrible fever, they had, they were in the hospital with high fever. These patients sometimes will develop MIH as well. So this is kind of a picture that is going to describe some of the characteristics of MIH. So the teeth are going to have like a creamish, yellowish color or brown color. You'll see irregular edges around the enamel, so it's not going to have the proper anatomy that a normal tooth is going to have. So you're going to see those wear facets quicker than you will on a normal tooth. You're also going to see ultra-translucency. So that's what you're going to see on the front teeth. So when you see those white spot lesions, or sometimes you can see the teeth that you get the light to shine straight through it, it is more insulting to the eye because it is not camouflaged with the rest of the tooth structure. So this is something that you'll see in the characteristics of MIH. So clinical challenges. Again, if these patients have not been properly identified and someone has treated them without a proper treatment plan or proper approach to them, they're going to be horrible patients. They're going to have dental phobia. They probably have had a bad experience. They've had an experience where the tooth has been worked on surgically and they haven't been done properly, or they're hypersensitivity. So a lot of these patients, if they've been treated before they come to my office, it is a behavior management complication because they've already had a bad experience. And nothing's worse than sitting in the dental chair when you're sitting with the anticipation of like, I'm going to feel this. And everything's going smooth, and all of a sudden, you jump out of the chair because you have, sharp pain. The hypersensitivity that I keep talking about, they're difficult to numb. Again, this is where your material science comes in. So these teeth don't really work well with resin because the enamel quality is lesser than that of normal. So, if you're doing your typical approach to composite, doing the etching, and opening the enamel tubules, this doesn't really work for those. And if you do those on these patients, they'll come out with complications. You'll see a lot of recurrent caries on these patients. And so this kind of gives you limited treatment options. You just can't treatment plan these patients the same way you do a normal patient. So you kind of have to think outside the box and know what's going to work for these patients and knows what's not going to work. So conventional stainless steel crowns, if you get to a point where the tooth is becoming non-restorable, enamel's chipping off, the tooth is hypersensitive, conventional stainless steel crowns is a nice transitory approach so that you can get them to 18, 19 years old so they can get a definitive restoration. But you have to manage the tooth while they're still in childhood and so that they can get to that point so it can be something left to restore when they get older. And like I said, last case scenario is, or worst case scenario, is extraction. So I like to prevent us getting to this point. So, if you employ proper preventative strategies, you shouldn't get to this point. But some patients you don't see till the end, and this is unfortunately something you have to do for these patients. So prevention, patient and parent education is key. You want to do an early diagnosis. Comprehensive oral hygiene instructions. These patients can't get away with brushing once a day or brushing intermittently. So you really want to bring them to your office and consider more of like a 3-month recall versus a 6-month recall. Sometimes I need to see them more frequently. Hygienist has to spend more time with them, going over the importance of hygiene, going over the importance of proper brushing and flossing. Diet education. A lot of the times when parents come in and they have severe early childhood caries, they have lots of cavities, and they ask, well, how did this happen? And then you ask, well, what are they going to bed with? Well, I'm from South Carolina, we like sweet tea down here. And so a lot of patients come in and say, yeah, we're putting sweet tea in the bottle and letting them go to bed with that at night. Or my child likes Mountain Dew and it's in a sippy cup. And so if you're able to have a conversation with them before they're doing that, you won't be in the situation that you are. So this is where the early diagnosis comes in. And then you want to apply focus to preventing the need for restorative and/or surgical treatment. So this is why this is very, very important. You want to catch them when it first comes in, and you want to properly identify and properly educate so you don't have to get to that point. So this is a little guide about the risk of certain foods, which will not likely cause cavities, will moderately cause cavities, and most likely will cause cavities. So low-carb foods like raw country vegetables, leafy vegetables, cheese, nuts, those things are less likely to cause cavities. Now, when you get into things like milk, smoothies, candy, ice cream, those have a moderate form of cavity development. But when you get into things like candy, soda, chocolate milk, I tell parents chocolate milk is like liquid dynamite for primary teeth. I see so many cases where you have widespread decay, and it's due to chocolate milk. And so a lot of parents come in and they say that, well, hey, my insurance plan, they paid for that, so it's healthy for the teeth, right? And I tell them, no, it's not. And so this is an opportunity to educate the parent and talk about these things that can contribute to a high cavity risk. So this is an example of an over-the-counter paste. This is a Kid's Crest Fluoride Anti-Cavity Toothpaste. It's going to have a little bit more toothpaste than a normal toothpaste, and it's going to help to reduce the cavity risk here. It contains stannous fluoride, and so this was the first fluoride compound added to the formulation of commercial toothpaste as an anti-cavity agent. And the antibacterial properties without the need of additional compounds or ingredients. So that's very, very important, something that you can use that is non-invasive, something that you can use at home to help reduce the cavities. Okay, so we're at some more board trivia. Everybody awake? Okay. So the next thing we're going to talk about is what is the maximum fluoride range of an over-the-counter toothpaste? Who said C? Right there. So it's number C. So it's 1,500 to 2,000 parts per million. Once you get above that, then you're kind of in the prescription. Alright, so now we're going to talk about the prescription range. This is something that you can't get over the counter, you have to prescribe it because it has a high level of fluoride. And if it's not properly treatment planned in the wrong hands or on the wrong patient, you can do damage. So this is something called Prevident or Fluormax. It's got 5,000 parts per million of fluoride. We call it a booster paste. It prevents white spot lesions, which are something that you have to really worry about for hygiene and also orthodontic patients. Fixed orthodontic appliances, if the hygiene is poor, you're going to see a lot of white spot lesions. I've seen a lot of these come back during COVID. So during COVID, patients have not had an opportunity to see their dentist on a regular basis, go to an orthodontist on a regular basis. And so after the braces have come off, we've seen horrible complications with the braces, white spot lesions, orthodontic scars, things like that. So once I see the first stages of that, we're giving them some kind of booster paste so we can kind of prevent that from happening. Patients who have a high cavity risk, if they come in, lots of interproximals, lots of smooth surface cavities, we're going to talk about that as well. Next thing we'll talk about is fluoride varnish. So fluoride varnish is something that we typically will do every 6 months. A lot of pediatricians now are giving those at well child visits. because the effectiveness has been shown to be very, very high. And so this is an example of a fluoride varnish that we use. Fluoride varnish interinstitutes enamel and makes the tooth hard. It will also prevent new cavities and slows down or stops decay from getting worse. If the decay is just starting, it can actually repair or remineralize the tooth without the need for surgical intervention. So it's been shown that enamel maxes its fluoride absorption at 2.5%, thus you'll see the 2.5% of the sodium fluoride. Some of them will come at 5%, but that's a little bit more than what's necessary for the biochemistry of the uptake of enamel, so the 2.5% is the most ideal. So this is another technique that you can use. This is something called MI-Paste. MI-Paste stands for minimal intervention. It's a topical cream that reduces sensitivity and remineralization. It also releases bioavailable calcium and phosphate in the saliva, and it contains something called recaldent, which is casein phosphopeptide amorphous calcium phosphate. This is something that is present in milk, and so if a patient comes in with a milk allergy, this is something that you do not want to give them. MI-Paste for 6 and under is great because it does not have fluoride in it, and it's great for pregnant women because you don't want to give them fluoride for obvious reasons. However, when they get a little bit older than 6 and a lot of the tooth formation is already done, you can give them something called MI-Paste Plus. This contains about 900 parts per million fluoride, which is similar to over-the-counter toothpaste. So this is an example of a sealant. Sealants are a widespread prevention technique that we use in pediatric dentistry. But this is something that is very, very important and very, very advantageous for a patient with molar incisal hypermineralization. As soon as that tooth comes in, you want to get it sealed. This brings us to our next board trivia. So in terms of sealants, what type of glass iron are they? Are they type 1, type 2, type 3, or type 4? Type 3, who said that? Right there. Good job. So some more challenges with sealants. Sometimes it can be difficult to achieve ideal isolation. So if you're using a resin sealants, if they're not properly done, you're going to see a lot of recurrent cavities develop around those. They can be time consuming. The younger phobic patient, sometimes they'll see the acid etch and they'll misconstrue that with a shot or a needle. And so that will make the procedure go more difficult than necessary. Sometimes when you have the etches on the soft tissue too long, it can cause chemical burns. And you can't seal partially erupted molars with resin because if you don't have that proper isolation, you don't have that full tooth structure to attach to, you're going to cause more cavities with the recurrent caries. Chipping and leaking over time with resin is very, very high, so that's something that every 6 months when they're coming in for their cleanings, you want to assess the condition of the seals. If they're chipped or partially erupted, you want to go ahead and reseal those. So this is an example of the leaking sealant. If you look on the tooth on the most right, you'll see that black border or that black edge around that sealant. Those are recurrent cavities. Those are counterintuitive to what you're trying to do because now you cause the cavity on that tooth, and now you have to fix the tooth with something that was intended to prevent a cavity. So proper material selection is very, very important. These are some examples of different materials. Embrace over here is a resin modified glass ionomer versus the Fuji, which is a straight glass ionomer. So resin-based sealants, they're most commonly used. They use micro-retention through enamel tags. They're hydrophobic, which means it needs to be completely dry. If you have any moisture, they're going to fail. More cost-effective material. The glass ionomer sealants, they're hydrophilic, which means that they don't need to have a dry feel. They can work with a little bit of moisture. They're not as reliant on moisture isolation, and the remineralization properties are the fluoride release, which is also going to be an additive property for cavity release. The other thing to consider is that glass ionomer sealants, they are way more expensive than traditional sealants. Each capsule costs about $5. And so you have the treatment plan based off of that and based off of what their insurance will cover. Sometimes insurance won't cover that, and I'll just say that, hey, this patient needs it, and I don't have problems selling it. The other thing to consider is more technique sensitive. The glass ionomer sealant is going to require trituration, like with an album. So you're going to have to put in the triturator, wait for it to mix, and then you'll be ready to move it. This is another article going over the effectiveness of glass armor sealants versus resin sealants here. This article said that there was no difference between the percentage of caries development with the use of glass armor seals versus resin-based sealants. And this is kind of opening a conversation, because if that's the case, then you don't want to be using something that's going to have a higher risk for developing cavities rather than something that's going to have a lower risk. So again, we're talking about these MIH cavities or MIH teeth. They don't, the etch process does not work as well on the enamel than it does on normal enamel. So if you have something that you don't have a proper etching field, and you don't have the enamel tubules that are open enough, it's not going to stick and it's not going to stay. So retention is a problem with the resin-based sealants. And the retention, if you lose retention, then you're looking at causing recurrent cavities. So this is something to consider. This article also said that the risk of loss of complete retention of sealing materials was associated with the risk of developing caries occurrence of resin-based sealants, but not for glass ionomer sealant-based sealants. The explanation of this result was that small particles remained in the bottom of the fissures and acted as a fluoride reservoir, and the slow release of fluoride was shown to reduce cavities. So that's very, very important. So now we're going to talk about restorative options for MIH patients. Challenges are age, hypersensitivity again, they're difficult to know, poor bond shrink to resin, and restoration failure. Recurrent cavities with the resin-based materials are also a concern. We're going to briefly go through this. This is the ART technique. This is something that Dr. Wilkes kind of went through. The ART technique is something where you don't use any kind of reduction of tooth structure. So you are just negotiating the cavities with hand instruments. So hand instruments such as a spoon excavator or a Hollenbach carver or an enamel hatchet. And this is an example here where you see they remove the cavities. There's no drill. So you're just removing the cavities that you can with a hand instrument, and then you're going in and filling in or condensing in preparation with the glass iron. This article stated that there's no difference in survival results between single surface atraumatic restoration technique restorations versus amalgam restorations and permanent teeth over the first 3 years. We all know that amalgam is kind of the tried and true restoration technique for teeth. And so when you see that something like such as an ART technique, which is a new material, has the same success over the tried and true, that's significant. I'm going to briefly go through this because we've already been through this. This is the silver diamond fluoride to arrest the caries, and then you're doing the glass ionomer cement on top of that to restore or remineralize. This is a picture here where the tooth initially was treated with the silver diamond fluoride, so you're going to see those black lesions. We typically like to let these patients sit for about 10 to 14 days to allow proper absorption into the tooth, and then you'll go over it with the glass ionomer cement for a more aesthetic appearance. Glass ionomer fillings, of course, they don't have the same wear resistance as resin-based. They do require a cavity conditioner, which is polyacrylic acid. The capsules require a triturator, and there's a very short working time. You have about less than a minute before this is going to harden and not be useful, and you have to start over again. This is a new technique called the band and glass ionomer cement technique. This is when you actually put an orthodontic band around the tooth to protect the proximal surfaces of the tooth, and then you put on top of the tooth the glass ionomer cement. This is something that is not going to be a definitive treatment option. However, it will buy you some time before the patient will need a definitive restoration, such as a crown or an extraction. This article states that temporary strategies are useful to preserve MIH-affected permanent first molars. With the methodology described, a hypersensitivity decrease and the patient reached a good degree of cooperation, making possible definitive rehabilitation considerations. This is the Hall technique. I'll breeze through this, but it's a minimally invasive approach that requires no local anesthesia or removal of tooth structure. And this is the worst case scenario, is when they come in, all 4 of their first permanent molars are bombed out, and you have to take them out. The second molars are not going to be affected due to the calcification times. So in conjunction with an orthodontic treatment plan, you can pull those second molars mesially to replace the first molars and give them a full set of dentition without having any occlusion problems. So this is something that is a technique that you can employ if you've lost any kind of restorative options for the patient. Lastly, we talk about cosmetic options. You can use MI paste. There's an etch bleach seal technique and icon resin infiltration. So this is a patient that presents with an anterior MIH defect. So you see those white spot lesions on the front teeth there. The mechanism of action is achieved by delivering bioavailable calcium and phosphate back into the oral cavities that are deficient. We already talked about the Recaldate technology here, which is a special milk-derived protein. So like, again, if they have allergies, you don't want to use that. This is a quick overview of the procedure. You want to do an acid etch procedure on the patients to take away the enamel superficial layer, and then you're going to apply the 37% phosphoric acid on the tooth for 2 minutes. After that, you're going to create a custom tray for the patient, and you're going to allow the MI paste to stay in the custom tray, and then it will reuptake into the enamel, causing remineralization. And it can also cause desensitization. It's important that these patients don't spit because you don't want to lose the effect of the MI paste on the teeth. This is a before and after. It's not a profound difference. However, this is kind of like your most cost-effective and your minimally invasive procedure here. And this also relies on patient compliance. They have to take this home. They have to use the paste. They have to use the trays. If they do not use those things, it's not going to work. So some pros. It causes remineralization. It's the least invasive option, inexpensive. Your assistant or your hygienist can apply, and it's good for patients with more time and money. The cons is it relies on patient compliance. If you have patients who are not compliant, it's not going to work on them. It will not work on every lesion, and it's time consuming. Mouth breathers tend to have a higher level of progression of the lesion returning just because of the enamel tubules becoming dried out. So that's something important to consider. This is the etch bleach seal technique. This is when you're using etch, and then you're going behind it with bleach, which is sodium hypochlorite to remove the organic material from the teeth, and then you're going back over it with the sealant. So this is a patient here that I had that had some brown lesions. Brown lesions tend to be a little bit more aggressive and stubborn than white spot lesions, so you want to use a more aggressive approach to get those compared to your white spot lesions. So of course you're going to do isolation. You're going to do the etch procedure, let it sit on the teeth for 2 minutes and rinse. And then after that, you're going to engage the tooth with the sodium hypochlorite. You want to agitate the tooth, and you'll start seeing, after you apply the bleach to the tooth, you'll start seeing that lesion starting to disappear, which is great. After that, you go over it with a clear sealant material. The clear sealant material is going to help reduce or prevent any further discoloration or staining after you've done the process. This is a before and after. So as you see here, this is a little bit more effective and a little bit more profound effect compared to your MI paste. However, it's more expensive, more time consuming. So again, inexpensive materials. They're more expensive than the MI paste, but it's a little bit more expensive. You can do this in one appointment, so does not rely on patient compliance. There's no compliance needed because you're doing all this chair side. It's great on ground stains and good for patients with more time and money. Less aesthetic for cons than icon. It will not work on every lesion, so you have to have proper case selection for this. And the sealant will not penetrate a lesion as thoroughly as icon infiltrate. So what we're going to talk about here is icon resin infiltration. This will end up our presentation. So icon infiltration is a newer technique. It uses an infiltration concept. It's a minimally invasive treatment. It does not require any injections, no tooth reduction, anything like that. It treats decalcification and symphony decay up to 1/3 of the outer dentin. And there's a high penetration coefficient resin which seals enamel porosities and creates a diffusion barrier which prevents further cavitation and breakdown of the tooth. So this is a kind of a before and after picture. As you can see, if you compare the MI procedure versus the etch bleach seal versus the icon, this is going to have superior results compared to all of those. Now, of course, everything comes with a con and pro. So the pros are, this is a one appointment, no compliance needed, superior aesthetics with all the options, and the results steady after whitening. The con is very, very expensive. The patients are having to pay about $500 to $600 a tooth for that. It will not work on every lesion, and it also blocks the opportunity for remineralization. So just in conclusion, you want to be able to identify your patients with MIH, prevent, restore. The other thing about prevention is you want to do good patient education. You can do this with techniques such as the MI PACE, fluoride varnish, or xylitol. And then you want to seal and protect fully erupted and partially erupted molars with a glass armor seal. Questions? Yes.
Another reason for lack of mineralization would be acid reflux?
Well, not really, because you're talking about acid reflux is more of an extrinsic thing, something that happens after the tooth has been erupted. But when you're talking about molar/slash hypomineralization, you're talking about when the tooth is calcifying, when the patient is either in utero or when the patient's an infant. So they typically are not going to cause that. Any other questions? Yes. That is what the research shows, is that it's more effective on deciduous teeth versus permanent teeth. There's not really a lot of research on permanent teeth, so I can't really speak on that. All right, well, thanks for your attention, and that concludes my presentation.